Hello, my name is Boris Ryabtsev. I am an emergency medicine resident physician working at Kendall Regional Medical Center in Miami, Florida. I would like to present the abstract of my sepsis research project entitled Blood Culture Results and Overtreatment of Patients with a 1-Hour Sepsis Bundle. Here's a list of authors who contributed to the project. I have no financial conflicts of interest to disclose. The 2018 update from the Surviving Sepsis campaign recommends the use of a 1-hour sepsis bundle to treat patients suspected of having sepsis. The bundle mandates the administration of IV fluids and antibiotics within 1 hour of patient arrival to the ED, as well as the acquisition of blood cultures prior to antibiotic treatment. Successful completion of the sepsis bundle within the required time frame is an important quality measure, and failure to do so is considered a fallout. The 2018 update is based on research suggesting that early treatment of sepsis reduces mortality rates. However, there is a lack of research into the utility of blood cultures and the possible overtreatment of patients with the 1-hour sepsis bundle. Our objectives are to assess the utility of blood cultures by measuring their true positive rate. We also attempt to elucidate which clinical factors are most predictive of true positive blood cultures. Additionally, we estimate the overtreatment of patients who are presumed to be septic. This was a retrospective chart review of patients for whom a code sepsis was declared by the ED physician on initial evaluation. The study included patients seen at 3 separate EDs within the same hospital system over a 2-month period. All of the patients were adults. We excluded patients whose records were marked confidential and those who arrived in cardiac arrest. We obtained various clinical information such as patients' vital signs, results of various blood tests, results of blood cultures, the names of antibiotics administered, and the diagnoses given on ED presentation and upon hospital discharge if the patient was admitted. Other data collected includes age, gender, race and ethnicity, presence of indwelling line or cardiac device, hospital length of stay, and mortality. The primary outcome of the study was the true positive rate of blood cultures of patients who received the 1-hour sepsis bundle in the emergency department. Whether the blood culture results were true positive or false positive was determined by an in-depth review of medical records during a patient's admission. Through the collection of comprehensive clinical data and utilization of logistic regression analysis, we sought to determine which clinical factors, if any, were most predictive of true positive blood cultures. To estimate overtreatment, we calculated the percentage of code sepsis patients who were diagnosed with sepsis or a bacterial infection upon discharge. A total of 544 code sepsis patients were included for analysis. However, no blood cultures were sent for 3 of these patients. Out of the 541 patients on whom blood cultures were obtained, only 7% had true positive blood cultures. Multivariate logistic regression analysis showed that abnormal temperature and lactate greater than 4 were the most predictive clinical factors for true positive blood cultures. However, a combination of abnormal temperature or shock index greater than 0.7 achieved a sensitivity of 97.4%. 45.4% of patients did not have a diagnosis of bacterial infection on their hospital discharge note, and only 33.8% had a diagnosis of sepsis. This is the first study to assess the clinical data from patients treated with the 1-hour sepsis bundle. We have determined that most patients treated with the bundle were ultimately not diagnosed with sepsis, and nearly half did not even have a bacterial infection. This suggests that the 1-hour sepsis bundle is associated with substantial overuse of antibiotics. However, future studies need to be done that would weigh the benefits of rapid antibiotic administration against the potential harms of overtreatment. We have determined that uniform acquisition of blood cultures on code sepsis patients has low utility because of the low true positive rate. Hence, blood cultures are unlikely to change sepsis management. We propose that only patients who have an abnormal temperature or shock index greater than 0.7 should get blood cultures, as this clinical decision tool has high sensitivity for true positive blood cultures. However, this decision tool requires external validation. Our conclusions are that a significant number of patients who are presumed to have sepsis are overtreated with the 1-hour sepsis bundle, as well as that blood cultures are useful in only a small subset of patients who carry certain clinical characteristics. Further studies are required to compare the harms and benefits of rapid antibiotic administration in these patients. Our proposed clinical decision tool may reduce unnecessary ordering of blood cultures, but requires external validation. Thank you for listening.